Next, you have Dr. John Jefferies, a cardiologist, and he's spoken for us many times. And Dr. Jefferies, in last minute, couldn't make it, so we're Zooming him in. So if you can start Dr. Jefferies' presentation. Hi, Dr. Jefferies, can you hear us?
Hey, Jerry, how you doing?
Well,
Good to see you.
Thank you for being here with us. Sorry, we're just a couple minutes late, but
That's okay.
and they have your bio, so they know all about you. So if you'd like to proceed, that'll work for us.
Yes, sir. Good to see everyone. Sorry I can't be there in person. Really appreciate you all allowing me to present virtually to you. And as Jerry said, I've had the great fortune of being there many times, and hope things are going well. So I was asked to speak about Fabry disease in the heart. We'll try and stay on time as much as we can, and we'll definitely try and leave a few minutes in for questions, because that's usually the most valuable part of this entire effort. So I am a cardiologist. I take care of both children and adults. So it means I train both in adult cardiology and pediatric cardiology. So hopefully I can answer any questions regardless of the age spectrum. So I don't want to belabor this too much, because you all know this very well, and I'm sure you've heard other lectures about this. But obviously, Fabry disease is an X-linked disorder. We know that there's a lysosomal enzyme deficiency, and because of that deficiency, we have a buildup of essentially toxic material. So that accumulates in pretty much every tissue and organ system. And we know that that has implications, obviously, for the kidney, for the cerebrovascular or neurologic system, and then the heart. And so we'll spend most of our time talking about what are the implications on the cardiovascular system, so meaning on the heart and some of the vasculature, and how does that all manifest as what we would say phenotypic disease, or what we have to deal with clinically to try and manage. And we also know that this accumulation of this substrate occurs in the embryo. So it starts before birth. And we so just de facto every day, there's potentially a little bit more, a little bit more, a little bit more. And that's kind of what this slide depicts, is that we know that there's this steady accumulation, but in really early life, it doesn't really result in any kind of symptomatic disease per se. But as it continues to happen, there becomes a threshold that is met where there's enough tissue involvement at an organ level where some of the symptoms may manifest. And obviously in the heart, that's one of the things that we talk about, is that when we get enough involvement of the heart muscle, or of the electrical wiring of the heart muscle, or of the vasculature that comes off of the heart, then we know that enough of that is impacted, then it starts resulting in symptoms. And those symptoms could be unusual heartbeats. The symptoms could be heart failure. So we hopefully, obviously, the goal of all of this is to catch things upstream, ideally before there is a significant amount of tissue involvement or any organ failure. And we would love to do that before symptoms manifest as well. Unfortunately, that doesn't happen all the time. And when things continue to progress, then it can lead to organ failure. So in my world, that would mean something like end-stage heart failure, or maybe we need to think about an advanced therapy like an LVAD, like a mechanical heart support idea, or even a transplant. And then, unfortunately, as we know, if we don't intervene, then mortality may be an outcome, which obviously we would all like to avoid. So this is kind of, I think, a really important slide, and as you all know far better than the clinicians do, this disease, once you start having symptoms, those symptoms usually stay with you, and over time, those symptoms become additive. So other symptoms become more apparent. So we know in childhood, we see a lot of the things that you probably heard about, like decreased sweating or no sweating, problems with heat and cold intolerance. And during childhood, those you typically would progress into adolescence and then to adulthood, that you would continue to have those symptoms. When you get into adolescence, we see some potential kidney involvement. We see some of the skin. The fatigue, which we even can see in childhood as well, is also something that's more remarkable. And then in adulthood is when we start seeing some of the things that drive what we would call morbidity and mortality. So we know there can be kidney involvement, there can be neurologic involvement, there could be brain involvement, and then obviously cardiac. And we say cardiac dysfunction, and it's not just about heart muscle dysfunction, it's about other things as well that we'll talk about that obviously is where I spend a lot of my time. So these are the majority, this characterizes the majority of the things that we pay attention to or worry about in the setting of Fabry disease. So we know high blood pressure, or what I would call systemic hypertension, is something that we see commonly. And that can be multifactorial as far as the cause. Sometimes that's because of kidney problems. Sometimes it's because of that deposition or substrate that we talk about can actually be in the walls of the blood vessels themselves that cause them to become dysfunctional. They can become stiff. They can react inappropriately to certain stimuli. And then obviously we can also see manifestations of blood pressure if your heart's not working well in the setting of heart failure. So it can be a multi sort of driven approach when it comes to elevated blood pressure. We talk about left ventricular hypertrophy or thickening of the heart is really common that we see in Fabry disease. And it's a pretty big deal. You might think, well, a thick heart, does that really matter? And it actually really does. When the heart becomes thick, it doesn't work as well. Specifically, it doesn't relax very well. So remembering the heart, to squeeze, it has to squeeze, but then it has to relax and fill with blood. That relaxation phase becomes impaired when you have a thick heart. And we know left ventricular hypertrophy in and of itself is closely associated with things like stroke. It's associated with heart failure. It's associated with heart attacks. It's associated with kidney dysfunction. So that's really, really important, and it's a common manifestation. We know the electrical system can become disrupted in Fabry. So the way that the heart beats, so the rate at which it beats can become disrupted. It can become too slow, or it can become too fast. And some of the rhythms associated with that can be problematic, and we'll talk a little bit more about those. But we also know just the ability of electricity to be conducted through the heart from the top to the bottom can become disrupted, and that's what's called conduction system disease. And we'll talk a little bit about that. We know the valves of the heart can become impacted, specifically the left side. On the left side of the heart is a thing called the mitral valve and then the aortic valve. So those two can be impacted, and they can become either stiff, or what we would call stenotic, or they can become insufficient, or what we might call regurgitant. And so we have to really pay close attention to that. We know the vasculature, like the blood vessels, can become impacted, as we talked about. Sometimes they can become dilated, and that's something that we pay attention to. Specifically, the big artery called the aorta can become enlarged. We know Fabry patients are at risk for having early heart attacks. And so that's really important, because that obviously is something that we would want to try and avoid, just because of the outcomes that are associated with that. And then lastly, we know sudden death is something that we have to be cognizant of. And it's usually because of unusual heart rhythms. So this idea of what's called ventricular tachycardia or ventricular fibrillation can all be fatal. So when you come to see me as a Fabry patient, these are the things that I'm worrying about. And it's not just this. I also have to think about the kidney function and the lung function and all these other things, because all of that stuff actually impacts all the things you see on the screen. So it's complicated, but that gives you an idea of kind of spectrum-wise what you should be expecting your providers to be thinking about. So, and this is kind of just sort of depicts what I'm talking about, is why is this? Like, why is this all happening? So we know we have this deposition of these sphingolipids, or the substrate, right? And that affects different cell tissues. And so the cardiomyocytes are kind of the muscles of the cell. So those are the parts of the heart that actually squeeze. Not all the heart is muscle. Some of it's connective tissue and electrical tissue and other things like that. But we know that the muscle can be directly impacted. So that leads to that thickening that we were talking about, and some of the scar tissue that we see. The endothelium is what lines the inside of blood vessels. And so when that becomes impacted, the endothelium is what's responsible for telling the blood vessel essentially to either open up or dilate or to constrict or narrow down. So when that endothelium becomes impacted, then the ability of what we'd say normal autoregulation becomes disrupted. So the ability of the blood vessel to open when it should or close when it should becomes impaired. We know the valves can be impacted, like we talked about, and it really is just because of that deposition caused thickening of those valves. And then lastly, this arrhythmia piece. So the heart conduction system is kind of like wiring in your house, and it starts at a central focus called the sinus node. And then that electrical impulse is fed out through different wires in the heart to get to all the aspects of the heart. So for it to contract, it needs to be stimulated with electricity. So that electricity starts in one little place and then it diffuses out around the heart. If those wires become broken or frayed in some way, then the ability of that electricity to get to where it needs to go becomes impaired. And that's what results in a lot of the things that we're going to talk about today. So this kind of gives you a schematic or a cartoon about when we think about the heart, how does it impact the heart? This is exactly how it happens. And this is just sort of a further expansion on all of that, is that a lot of what drives what I worry about in Fabry disease is death of the cell. So an idea of a thing called fibrosis or scar tissue. And that leads to a lot of the problems that we deal with, not only the relaxation problems, but ultimately sometimes the squeeze problems that we see. So ideally, what we would love to do is to avoid that cell death kind of phenomenon, or what we would call that ultimately results in a thing called fibrosis or scar tissue. And this is a busy slide, but if you can take a picture of this and kind of refer it to it as you need to, it really captures most of what we think about at a Fabry center when it comes to the management of heart disease. So, and it has a lot of other things as well in here that are just, non-cardiac clinical manifestations of Fabry. So you see all these different things like unexplained arrhythmias and chest pain, which really feeds into a lot of the things that we've been talking about. But you see a lot of the things in the bottom left are the electrocardiographic findings, so the rhythm problems. So every time you go, and we'll talk about what an ECG is, but these are a lot of the things that we may see. And the first things we see are a slow heart rate, which is that word bradycardia. We see the laboratory findings. So you've heard a lot about, or you will hear a lot about, definitely through this conference or other conferences, lyso-Gb3, which is a very specific biomarker to Fabry. But we see other things like NT-proBNP or troponin, which is what we see in the bottom right of this screen. Those are all blood markers that we follow in the setting of heart disease that I would do on anybody, regardless if they had Fabry disease or otherwise. And then at the top right is something we'll spend some time on through the rest of the lecture, is how can I actually get an idea if any of this stuff is going on? Is the heart thick? Is it not working well? All that sort of business comes through imaging. And so we'll talk about different modalities of imaging and some things you want to ask your clinicians to pay attention to. So we talked about this, but these are the kind of things that are really we hope to avoid, because once you have these, they're really hard to reverse. So it's really hard to go back to baseline. Once you experience heart failure, once you experience myocardial ischemia, or another word for that would be a heart attack or a stroke. So obviously our goal should be to avoid those, because once you get them, it's really hard to undo all of that. We know heart stuff is really common. It's the leading cause of death in Fabry. So we pay a lot of attention to this. And I think we're getting better at detecting it and managing it in the current era. So as I've said, as a cardiologist, a lot of what we do is reactive. So somebody has a heart attack, we put a stent in them, or somebody has heart failure, we treat them with medications. But obviously the ideal thing is to be proactive. We would love to avoid those sorts of things. So it really has prompted us, I think, to be better at screening for those sorts of things and intervening a little bit earlier, because the prognosis is just negatively impacted once we see evidence of these things going on. So let's drill down a little bit into each of these kinds of verticals and help to give you maybe a little bit broader understanding, but more importantly, the goal of this lecture for me is to empower you. So you walk away with information that you can go back to your providers and say, hey, have you been paying attention to this? Or, hey, are we looking for this? Or if I have this, what are the treatment opportunities? But you'll be, you'll be well versed, and hopefully you'll be able to educate your providers as well more about Fabry disease and some of the cardiovascular implications. So we know these unusual heart rhythms, or what we call arrhythmias, are pretty common. And the things that we know is that they can either be too slow. So that's the idea of a bradyarrhythmia. And in an adult, that would be less than 60 beats per minute, typically. Or they're too fast, and that's the tachyarrhythmia. And that's when it's over 100 beats per minute. And so we can detect this in a variety of mechanisms, and it's really important. So, slow heart rhythms are something we know are really common, and one of the earliest manifestations of heart involvement in Fabry is a thing called bradycardia. And a slow heart rate in and of itself does not necessarily warrant an intervention, but sometimes the heart rate can become so slow that you can't do the things you want to do. So that's what's called symptomatic bradycardia. And we see that here is that, and I don't expect you to pay too much attention to this, just to recognize that this is a slow heart rhythm. And ultimately, that means that we may have to put a pacemaker in. So because the heart inherently can't beat fast enough to keep up with the physiologic demands, maybe we have to help it. And that we help it in the form of a pacemaker. We also know, as I said, that electrical system or wiring can become frayed or even broken in the heart. And that's through a thing called the QRS complex. So any of you have had an EKG, you see this pink piece of paper with these cool little squiggly lines. And those squiggly lines are represented in the thing on the left with a P, a QRS complex, and then a T. So that QRS complex is basically where all of the activity in the pumping chambers of the ventricles is going on. And when that becomes spread out, that tells us that efficiency of conduction is becoming perturbed. And that's called a QRS complex. And every EKG you have at the top of it has a QRS duration, and it'll be measured in numbers, and then it'll have an MS after it. And that MS means milliseconds. And anything that's over 110 milliseconds would be representative of conduction system disease. So anytime you get one of your EKGs on your patient portal, this is something you can pay attention to, and you should alert your physicians if you're seeing something like that, simply because on the right you see that survival is actually poorly or negatively impacted once that number starts to increase. So just a basic thing that you can look at on every EKG. The other way we look for any kind of electrical disturbances is here. So you see 4 different pictures. And the top left is just a traditional EKG. I'm sure many of you have had one of those. Great technology, but it only gives me about a 2-minute snapshot into what's going on with you. And let's say some of your symptoms are sporadic, so you're not having them all the time. Maybe I need to look for something more continuous. Give me more than 2 minutes. That's what's on the top right. That's a Holter monitor. Sure, many of you have worn those, and they're not a pleasant thing to experience, but it gives me about 2 to 3 days of electrocardiographic data. So if something happened in that 2 to 3 day time frame, I can see it. Let's say I don't capture it then maybe I need longer monitoring, maybe for a couple of weeks. That would be in the bottom left. So that's a wearable patch that lives on the outside of the skin. That you can wear and shower with and those sorts of things. And that gives us data for a longer period of time. Some people occasionally just don't have symptoms in a predictable way. Maybe they only happen every 3 or 4 months and they're completely at random. Then we might think about, well, I really need to know what's going on with the rhythm because it can be something catastrophic. Then I would think about the thing in the bottom right. That's called an implantable loop recorder. So that's about a thing about the size of a paperclip that we put under the skin that can give us continuous data. So just like you're on the EKG machine for up to 5 years. So that's really helpful for us because it can help us diagnose things like atrial fibrillation, but it also can help us diagnose fatal arrhythmias like ventricular tachycardia. And that's what you see here. So this is what those kind of jagged looking things in the middle of that strip is ventricular tachycardia. And that's what you see people getting shocked for on TV, because if you don't resuscitate someone with that particular rhythm, it can be fatal. So these are kind of some of the ways we would think about looking at rhythm problems. The other piece is the imaging. So remember, I also need to see how big the heart is, how thick it is, how big the chambers are, all that kind of stuff. And this is where we do ultrasound of the heart or an echo. And an echo, I'm sure many of you have had. So great technology has been around for multiple decades. It's really portable. Everybody has access to it. So that's the main reason that we use it. So it's a great tool because it can tell me how thick the heart is. It can tell me how well the heart is squeezing, and I can do it pretty easily almost anywhere. And these are the bottom of this screen is what I want you to pay attention to. So you see where it says a normal heart, and then it also says a dilated heart. This picture in the middle where it says hypertrophied heart is what we typically see in Fabry. And you can get an idea just visually where you see that this is what a normal heart on the far left would be and how much thicker that heart in the middle is. That's LVH or left ventricular hypertrophy. Once that happens, once again, like we talked about, that's where these problems with stroke and heart attacks become more evident. So we would love to avoid that. And this is an echo picture. If you were to see this, so on the left is what a normal heart looks like. And this thing that says LV is the chamber that we're actually paying attention to. And the white part of this whole picture is the heart muscle. The black inside is blood. If you look on the right side, you see this left ventricle is much thicker. So the muscle is greatly thickened, probably about 3 times thickened where it should be. And so obviously that makes this pumping chamber inside much smaller, and the ability to relax becomes impaired. So that's what left ventricular hypertrophy looks like. We can also get fancier stuff from echo. So we can do in more advanced centers, we do a thing called strain and strain rate imaging. And if you're not getting this, you should ask your provider. This is basically a way for us to detect some of that thickening before it happens. So an idea of which patients are kind of on the road to developing that thickening. You don't go from normal to 3 times thickness overnight. It's a gradual process. And the point would be is if we knew it at the earliest point when it's starting to happen, maybe we can intervene, at least pay more attention. And that's exactly what strain imaging does. Is it tells us that, and the way to look at this is pretty simple, is if you see all red, which you see on the left, this is all tissue that's normal. And then you look on the right and you see that you have a different color. You have yellow or green, and that tells you that the tissue is abnormal. So this is an area, this is one where we're starting to see some early changes in the heart muscle itself that we have to pay attention to. So just 1 second here. Sorry about that. So, so this is an easy tool that you can use that your providers can leverage in the setting to look at echocardiography. The other piece is cardiac MRI. So this is kind of when I explain this to patients, it's like the echo for the people that are old enough in the room is kind of like black and white TV with an antenna, right? That's sort of what echocardiography is. So you see something moving, but it's not really high definition picture. It does really look like black and white when you see it on the screen. MRI is kind of like the 4K version of that imaging. So it's very precise. You see all the detail, you see the color, all this kind of stuff, very vivid imagery. That's exactly what MRI is. And what it does is it can actually tell us very specifically what's going on at the tissue level. Is the tissue abnormal? Has it been damaged? We talked about scar tissue. I can't see that on the ultrasound, but I can see it on the MRI. And so that's the real advantage. And it gives me really precise measurements. I can measure down to the millimeter how thick the heart is in a very precise and reproducible way. And that's what we see here. But the other piece is that I can give you a contrast agent called gadolinium. So we get an IV every time we do an MRI. And with that, we can actually look for areas of scar or damage. And that's exactly what we see with these arrows here on the far right. Those arrows are pointing to this sort of gray looking tissue here in these sea of black. That gray represents scar. And the technical terminology is late gadolinium enhancement. So it should be all black in that area. It's actually got some white tissue in there. And that represents scar or fibrosis. That's important for a couple of reasons. One, the fibrosis piece doesn't squeeze. So that heart muscle that should be squeezing now does not squeeze because it's been replaced by scar tissue. The second piece is that scar tissue actually is disruptive to the electrical pieces that we talked about. So the electricity is trying to travel through and it hits a roadblock in the form of scar. That creates a lot of the heart rhythm abnormalities that we just talked about. So that's one of the huge advantages of MRI. But that contrast agent that I was talking about, we can't give it in people that have advanced kidney disease. And we know that that's really common in the setting of Fabry, is that thing called your estimated GFR starts to decline. And once it gets below a certain level, we cannot give you gadolinium anymore. So the question is, though, I still want to see if there's scar tissue. How can I do that? I can do that with a thing called T1 imaging. And that's what native T1 imaging is, basically looking for that scar tissue on an MRI without having to give you the contrast agent. And it works. And that's what this picture depicts here, is that it is telling us that I can actually use this T1 imaging to identify the scar. And I can react to that as a cardiologist, pay more attention to that. And I don't have to expose you to the contrast agent. And most places that you would go that do cardiac MRI would be able to do something like this. Last thing I think is something we don't talk a lot about, but Dr. Hopkin, I saw him drawing raffle tickets there a few minutes ago. This is something that we published a few years ago, this idea of lymphedema. So lymphedema is a really complex problem that's hard to treat. And basically, when you think about lymphedema, visually, it's almost like this idea, if you've ever seen this idea of elephantiasis. So when people's limbs can become swollen unilaterally or on both sides in a really, massive way. And I'll show you a picture in just a minute. This is important because we talk about arteries and capillaries and veins as your circulatory system, but the lymphatic system is a completely separate system that drains into that venous system. And it's different than traditional edema than what I would see in heart failure. So the way we treat it is very different. So if I were treating you and I thought you had heart failure, swelling because your heart wasn't working well, but you actually had lymphedema, I would actually potentially do harm, because that's not the cause of the problem. It's not swelling because your heart isn't working. It's swelling because your lymphatic system is not working. And this is a picture of lymphedema. And we have $1 or $5 bill there as a scale for you to compare. This is lymphedema. And it's actually pretty common in Fabry disease, maybe 25, 30% of patients. My point of this is a simple one. If you have this, you need a different treatment than water pills. And this is something that needs to be worked up and managed completely differently. So I just want you to be aware of this, because 1 in 4 patients with Fabry will likely experience lymphedema. And I want to finish up, so I know we have some questions. Our goal is a simple one. We try and catch things as upstream as possible. I do surveillance like we just talked about for males and females exactly the same. I treat everyone the same as far as their risk for cardiovascular disease, just because I know the more that I pay attention, the better off we're going to be. And these are some of the cardiac red flags that we've talked about. You heard about all of these things during the course of this conversation. The things on the left are all the things you can hear about from everyone else. It's all the stuff that is not directly related to the heart, but actually does have important implications on the heart. Our approach, as I said, we see patients of all ages, the kids. Even though we know that the cardiac involvement is not commonplace in a young child, we still need to be aware that it's something that's going to happen in the future. And we just want to be ahead of that as much as we possibly can. These are all the testing modalities that we talked about. We do a few other things too, but they're beyond the scope of this talk. And as I said, we try and be comprehensive and repeat it. So if you came to see us or any other, comprehensive center, we do all the stuff that we talked about, but it's not a one-shot deal. We do those in a longitudinal way, meaning every year, every 6 months, we're going to be repeating that stuff because we know it can change over time. So in conclusion, broad spectrum of disease, cardiac's main cause of the outcomes that we see from a morbidity and mortality perspective, and Fabry definitely the mortality piece. And obviously it's something that I think we have a lot of therapeutic options for in 2025. So with that, I'll stop. I appreciate your time, and I'm happy to entertain any questions. And my email is here. So please always feel free to reach out to me directly if there's anything I can do. And obviously, Jerry knows how to find me as well. So thank you for your time, and happy to field any questions. Hopefully I can provide a good answer.